IHR. He's the co-director of Diabetes MSc at Leicester Universities. He's part of NICE guidelines in prevention of diabetes, and is a clinical advisor to NICE, who frames excellence works and tells the whole country or the world as to how we should move forward in management of patients. So over to you, Dr. Kamlesh Kunti, sir. And while Dr. Kunti loads up his slides, I shall just introduce the topic. Dr. Kunti is there? Dr. Kamlesh Kunti, sir? Dharmender?
Dr. Kunti is there. He is going to talk on dissecting CDO.
I shall introduce Dharmender. Dr. Kunti has not come on the video yet.
Yeah, meanwhile I request, let us...
Can you hear me? I'm here.
Yes. So if you could put up your slides, and while I introduce the topic to you, Dr. Kunti.
Okay.
Let me just share screen and bring the topic up. So Dr. Kunti is going to talk about dissecting the cardiovascular outcome trials, what pharma does not tell us. Now, the importance of this talk is the whole world is divided into three groups, I would say. One are the academicians, the two is the clinicians, and three is the statisticians. And very often the clinicians do not have much idea what the statisticians are saying. And the academicians are to guide, I would say, the interface between the statisticians and the clinicians to the cardiovascular studies that are going on. Very often, the pharma, because most of the trials are done by pharma companies, and very often they only show one side of the coin. So Dr. Kunti is going to tell us today about what is that, the hidden agenda, what is it that has not come out in the open, and as clinicians, we should question when somebody talks about the trials. Dr. Kunti, sir.
Sorry, can I just ask, this is, if you hold on, please, I'm just going to get my slide deck. This is about the cardiovascular outcome trials, because I've got two talks.
Yes, this is about the cardiovascular outcome trials, sir.
Okay. Can you see my slide deck?
No. So you might want to open it another window and do slide share. Have you taken the share screen, sir?
Yeah, I've done that. Hold on.
Just open
sorry about this.
The window and.
Can you see my screen now?
No, not yet.
I am sharing it, but nothing's happening. I'm trying to share it now at the moment.
Dharmender, do you have Dr. Kunti's slideshow?
Just let me just have it. Or else.
So.
I'm sorry about this. I sent this yesterday. Everything was working, which I did a slide share yesterday as well.
No worries. What we'll try to do is that if you might want to say next, and Dr. Dharmender would actually move on.
I can certainly do that.
Yeah, would that be okay? Dharmender, are you ready?
Yes, sir. I'm just checking it out, or if it is possible, we can postpone it for one session, and we can.
Okay.
Dr. Sanjay Agarwal.
It'd be better if I can do it now, if that's possible.
Yes.
Okay. Dharmender, can you load up his slide deck?
Yes.
Can you see me now?
Yes, we can.
Yes.
You can share my screen now?
Yes.
Yeah, you might. Yes. So if you go on.
It's 3 o'clock.
Yeah. Yes.
You can see the screen now?
Yes,
Yes.
we.
Okay, can I start?
Yes, please.
Okay, so thank you very much, friends, colleagues. Sorry you can't be there like everyone else, but it's a complete honor to be with you. You can see my slides clearly now?
Yes, please.
Excellent. Okay, these are my disclosures. Just a little bit about myself. I'm from the Leicester Diabetes Centre in the UK. We're about 100 miles north of London. Professor Melanie Davis and I are the co-directors of this centre here. Leicester, as I've said before, a multicultural city, lots of Indians here. And I'm of Indian origin, originally from Porbandar, only lived there 2 years of my life, but I love coming to India, as you all know. So for the next few minutes, I'm just going to take you through background of cardiovascular outcome trials, the expected and unexpected findings, the reasons for the differences, the limitations of cardiovascular outcome trials, the future trial designs, and a summary at the end. In terms of cardiovascular outcomes, we know type 2 diabetes significantly increases the risk of cardiovascular events. If you look at it overall, coronary heart disease, myocardial infarction, different types of strokes, we have a twofold increased risk. And we previously had a number of trials which didn't have cardiovascular outcome trials or safety, but it was this paper that led to a complete change in how cardiovascular drugs and diabetes drugs were mandated for the future. As you know, this was Nissen who showed that rosiglitazone was associated with significantly increased risk of myocardial infarction, with an increase in the risk of death from cardiovascular causes that had borderline significance. Prior to this, companies only had to show that there was glycemic efficacy. And we had a number of studies that showed rosiglitazone improved HbA1c. There were also studies showing they improved intermediate outcomes, for example, carotid intima thickness. But it was this meta-analysis that really showed that there was an increased risk associated with rosiglitazone. And as you know, after this, the FDA had a requirement that new anti-diabetic therapies to treat type 2 diabetes are not associated with unacceptable increase in cardiovascular risk. And this was guidance for industry. And they brought out these criteria for requirement of post-marketing cardiovascular outcome trials. As you can see here, they had non-inferiority bounds for hazards of 1.3, 30% increase, and this is hazards of 1.8, 80% increase. So superiority was shown if the hazards were below this margin of 1 and didn't cross the margins, or non-inferiority didn't cross the margin. Approval was not needed for post-marketing study. For non-inferiority, if the boundaries crossed 1.3, approval was needed for post-marketing study, and inferior or underpowered studies which crossed 1.8 margin were not approved. And since then, we've had a number of studies, and I'll just take you through shortly about the expected and unexpected findings. As you know, we've had a plethora of studies over time, and these are the studies, and some of them are still ongoing. We'll see some great studies coming, especially looking at renal outcomes and hospitalization for heart failure. And there are studies, as you know now, with glucose-lowering therapies in people without diabetes, which is quite an exciting area in itself. But as you can see, huge numbers of studies, thousands of patients randomized into various new glucose-lowering therapies here. So if you just take you through some of the highlights that we've seen, this is for DPP4 inhibitors. And can I just reiterate, these trials were to assess safety of new glucose-lowering therapies. In terms of DPP4 inhibitors, we had Saver, Timi, Examine, Ticos, and Carmelina, and all of them, as you can see, hazards of 1. So no issue in terms of cardiovascular safety as primary outcomes. However, there were some unexpected findings. For example, Saver, Timi showed that there was increase in hospitalization for heart failure, a signal that was not seen in the other DPP4 inhibitors, sitagliptin, linagliptin, and allogliptin. Then we look at cardiovascular outcome trials with SGLT2 inhibitors. Here, I'm just looking at the MACE outcomes first of all, and we see that EMPA-REG was the first trial showing a 14% relative risk reduction. Canvas showed the similar results. Declared Timi a 7% non-significant. All the yellow ones are non-significant, crossing the line of unity. Vertis CV just recently announced, again, did not reach statistical significance. Cardiovascular death, only EMPA-REG showed cardiovascular benefit, but all of them are consistent in showing hospitalization heart failure benefits. This was not expected, as you know, so this was an unexpected finding for hospitalization for heart failure. If we just look at Vertis CV, and when Vertis CV results were announced, we were expecting we'd have the same results, because we keep saying there's a class effect with SGLT2 inhibitors. Vertis CV, and if you compare that to empiric outcome trials, the number of patients is very similar. These are all patients with established cardiovascular disease. Overall, we see here very well matched between Vertis CV and empiric outcome. Hospitalization for heart failure, previous history of heart failure slightly higher in Vertis, mean EGFR similar, and patients with an EGFR stage 3 very similar as well. But we still saw differences in outcomes. That's one, we're all wondering why that is the case. We go to GLP-1 receptor agonists. First one was lixisenatide, and then since then we've had a number of studies here, and as we can see, again, not consistent findings. The longer-acting GLP-1 receptor agonist showing reduced cardiovascular outcomes, but the short-acting ones did not show this. Pioneer was not a full cardiovascular outcome trial. We are awaiting that at the moment. But overall, quite consistent results here for the longer-acting GLP-1 receptor agonist. As we said, hospitalization for heart failure was an unexpected finding, and we see this here. Some secondary analysis from meta-analysis of the 3 outcome trials we've had with DECLARE, TIMI, CANVAS, and empiric outcome. And as you can see, consistent reduction in hospitalization for heart failure, but more so in people who had worse EGFR, not so much for people with normal EGFR, which is an interesting finding in itself. Another unexpected finding was in terms of the fracture. This was seen in pooled data for CANVAS and CANVAS-R, and what we saw was overall significant reductions in all fractures. Low trauma fractures did not reach statistical significance. And the other unexpected finding from SGLT2 inhibitors, we see a consistent improvement in a composite of renal outcomes. Here, the composite being worsening of renal function, end-stage renal disease, or renal death. And this was consistent across the EGFR categories of normal EGFR all the way down to EGFR of less than 60. An unexpected finding, but a very positive finding, and we now have indications that we can use this in people with renal disease. And as you know, we're expecting results of the trials in people with and without diabetes. So what are the reasons for these differences? Well, there's a number of reasons. There's varying inclusion and exclusion criteria, the duration of trials. Some of the trials are event-driven, some are duration-driven. There may be differences in mechanism of action, and certainly we see this in the GLP-1 receptor agonists, where there is a difference with the short-acting and the long-acting ones. The cardiovascular risk factors that the inclusion criteria included varied quite enormously, and the methods of conduct of the trial as well. Just to give you an example here, differences in cardiovascular designs and patient populations. This is SAVOR, TIMI, EXAMINE, TCOS, and ELIXIR, MPERAG, LEADER, and SUSTAIN. As you can see, these are the inclusion criteria. They vary quite hugely. Baseline age, about a 5-year difference between the different trials. The inclusion criteria in terms of HbA1cs, they had differences in terms of inclusion criteria. The baseline HbA1c of these studies was variable as well. I'm not going into the blood pressure variabilities, the lipid variabilities, but there are differences in terms of the inclusion-exclusion criteria. So what are the limitations of cardiovascular outcome trials? Well, cardiovascular outcome trials have provided us important evidence regarding cardiovascular outcomes and their safety and efficacy as well. Regulators still wanting to retain one large cardiovascular outcome trials for new glucose-lowering therapies, but if you look at the cost of cardiovascular outcomes, it's from anything from $200 to $500 million, and this is just not sustainable. There are discussions within companies that if they are not sure if that molecule is going to have positive effects, then there is innovation that's being cramped down by not taking that molecule forward to do a cardiovascular outcome trial. So now we need to start thinking about more refined studies, and I'll come to that later. There are other limitations of cardiovascular outcome trials. There is lack of generalizability. Current cardiovascular outcome trials do not include participants with very high risk sometimes, people who are very elderly. So they're not representative often. The timelines for assessing potential benefits may be too short. We really need to have outcome trials for longer than 5 years, and many of the ones we've had so far have been less than 5 years. Potential harms, again, we can't see them if they're short trials. And there is discussion that normally we would need to compare this with another glucose-lowering therapy. And we know Carmelina, Carolina was the first trial where we saw head-to-head with a glucose-lowering therapies with linagliptin and glimepiride. But otherwise, all the studies are looking at placebo, trying to get glycemic equipoise, but we know that glycemic comparability is often not achieved, and we see lower levels of HbA1c in the intervention arm with the active drug, which may contribute to the cardiovascular benefits. Some of the drugs that are used in comparison in the placebo arms may have more adverse events, for example, sulfonylureas, the TZDs, etc. And so we do need to start thinking about the limitations of cardiovascular outcome trials. Just to take you through about the representativeness of people in cardiovascular outcome trials, this is a study published last year looking at all the SGLT2 inhibitors from 4 European countries. And what we see is these are the eligible patients at population level. So for example, the VERTIS and the EMPA-REG outcome trials results would only be applicable to about 1 in 5 to 1 in 6 patients. The declared TIMI, there was more representativeness, more at population level, but there are huge limitations, as you can see. If we look at GLP-1 receptor agonists, how well do they reflect the population level in the US? But this could be applying to any country. And REWIND was the one that had the most number of patients that were representative at population level, 42%. And the others, again, anything from 13 to 15%. And if we look at all these trials here in terms of the GLP-1 receptor agonist, adults with type 2 diabetes who would meet all these criteria, any GLP-1 receptor agonist cardiovascular outcome trial, 64% would have matched one of them. So 35%, even 35% would have not matched if you put them all into these therapies. And if we say, would they meet all of them? Only 1% of the population would meet all of these criteria. We know contemporary cardiovascular outcome trials, these are the designs. It's the determination of drug X against a placebo and very rarely a comparator. Identify high CV risk patients. There's a run-in period, randomization, and composite outcomes, which are event-driven. However, when we look at it, these are very well-designed studies. Tight inclusion-exclusion criteria, as you can see here. There's a placebo run-in. In real-world setting, we don't have a run-in. Drug X versus placebo, and these patients are seen at regular intervals, for example, 3 weeks, 13 weeks, 26 weeks, and so on for the length of the trial. These are face-to-face interventions, and then they're also seen by phone as well. We don't do this in routine clinical practice. These patients are seen maybe once a year. Some of them may be seen 3 to 4 times a year at the maximum. So we don't have this type of luxury in routine clinical practice. So we need to start thinking about the future of the trials. So there are alternatives. The standard guidance for use of interim CVOT data may be there to support approval of new drugs. Minimum requirement of duration of cardiovascular outcomes needs to be discussed. We could think about passive follow-up, which is much more cheaper and more in line with routine clinical practice. We could use observational data to complement the randomized controlled trials. And there were discussions that cardiovascular outcome trials could maybe just be used for the first in new class, but we've seen that that could also be dangerous with the recent results that we've seen. So there is interest in pragmatic trials. So this is the evidence continuum, the phase 3 trials, what we see. Then we have the long-term, phase 1 trials, and then phase 3 trials here. where the cardiovascular outcome trials fit in, but then we have the observational study, but in between there is the pragmatic randomized controlled trials. Let me just shortly tell you a little bit about pragmatic randomized controlled trials. As you know, no trial is completely explanatory or pragmatic. There is a continuum. The explanatory trials that I've just mentioned, the cardiovascular outcome trials, tell us, can that intervention work under ideal conditions? They give us the internal validity. A pragmatic trial tells us, does an intervention work in the usual care setting? They give us the external validity. And we really need to balance something between these two so that we're maximizing trial efficiency and conduct with the cost and generalizability as well. And I'll give you an example of a cardiovascular outcome trial we did. This was the Anglo-Danish study of intensive treatment of people with screen-detected type 2 diabetes in primary care. UK, we led it from the UK with Cambridge, Denmark, and Netherlands. At 5 years, we saw a 17% non-statistically significant reduction in a composite cardiovascular outcome. But all the outcomes were assessed using primary care and hospital records. This was a pragmatic trial. The cost of this trial was £4 million for a 3,000 patient 5-year cardiovascular outcome trial. Fraction of a cost of the trials that I've just mentioned. We've just done a 10-year follow-up of this, and that cost us £1 million only for a further 5-year follow-up. So it is possible to do cardiovascular outcome trials at a lower cost. And for this trial, we had 98 to 99% ascertainment for the composite cardiovascular outcome. And finally, just to take you through the new US FDA draft guidance that's online at the moment, because FDA have obviously been thinking about these, and there have been discussions that we do start to think about alternative ways. And some of the recommendations, and this is, as I said, draft for consultation, that at least 4,000 patient years exposure to a new drug in phase 3 clinical trials should occur. The exposure would include all dosage strengths studied in phase 3 clinical trials. At least 1,500 patients should be exposed to the new drug for at least 1 year. At least 500 patients should be exposed to the new drug for at least 2 years. At least 500 patients with stage 3 to 4 chronic kidney disease should be exposed to the new drug. At least 600 patients with established cardiovascular disease should be exposed to the new drug. And at least 600 patients older than 65 years of age should be exposed to the new drug. So in summary, cardiovascular outcome trials have provided us fantastic risk-benefit evaluations. They were designed to show safety of new glucose-lowering therapies, but findings have changed the paradigm of management of type 2 diabetes. And now we're seeing, if we didn't have these trials, we wouldn't be using them for alternative indications, for example, hospitalization for heart failure and renal disease. And these drugs are now going to be tested in people without diabetes. The scenario now is we do not look at HbA1c, we really look at that phenotype of the patients and start the therapies. So new indications of these therapies have come through these unexpected findings. And we now really need to start thinking, and I'm really pleased that FDA have started thinking about improvement in trial designs to make them more efficient, generalizable, and cost efficient. Thank you very much for listening.
Thank you, Dr. Kunti. That was excellent. I've got a couple of questions while people type in their questions. Most of the cardiovascular outcome trials do not take into account the disease duration of the patient. Does that, do you think that's important? And is there something that one could consider that in the interpretation?
I think we should, sorry, can you see me now?
Yeah, don't worry.
Okay, yeah, I think it's really important that we do take into consideration disease duration. And the reason is we've seen that some of these trials, we're seeing that these therapies need to be started early. And that's an important issue, that if we get good findings that we start these patients early in the disease continuum, then we can start changing guidelines. You know, after metformin, we've already started thinking about GLP-1 receptor agonists and SGLT2 inhibitors. But at the same time, we want to know that if patients are on 3 oral therapies, are these new therapies going to be beneficial? So we do need the continuum from early to late.
Okay. The other question that I have is that, you know, from a clinician, a practicing clinician point of view, who's not an academician, very often pharma would show a comparison. If we take into SGLT2, we will have the ones that, that we had a slide of that, the yellow ones and the green ones, which is significant and which is not significant. But a patient population is different. The inclusion criteria can be different. And that causes a conundrum in the mind of the clinician. How should he go about in a clinical practice?
Okay, so this is where I say there are various ways to do this. First of all, if we had a pragmatic trial and we had a greater level of inclusion of patients that is generalizable to the patients that you and I see in clinical practice, that's one way of doing it, to see if we see this in a pragmatic trial. Now, if you look at the exenatide long-acting study, that just missed significance, as you know, for MACE. And the reason there was, that was a pragmatic trial. People were seen 6 monthly rather than on a regular basis. That's, to me, that's an important information that people are not talking about. Secondly, once we have the exploratory trial, I think it's good to have really large, good quality real-world evidence. And CVD Real, which I was fortunate enough to be involved with, has really upped the game in terms of how real-world evidence should be generated of comparative effectiveness study. So we want to see in an exploratory trial, is that drug working, and then see if we can translate that into the real world using the good techniques that we've got, using good databases to see if it's applicable, not just the trial population, but patients who may not have been included in the trial.
And last question, Dr. Kunti, is very often, should it be mandatory, I would ask you, in all trials that they report absolute risk reduction or number needed to treat, to make it simplified across the trials for clinicians to actually understand the whole scenario?
I couldn't agree with you more. I think numbers needed to treat is a concept that most people can understand, most clinicians can understand, even patients can understand that. And I think when we're in our conversation with our patients, we can give them a choice that I've got this injectable therapy, which may have a lower number needed to treat, compared to an oral therapy that may have a higher number needed to treat. I think that's a conversation we can have with our patients. But in terms of trials, we can easily look at numbers needed to treat by having them on one head-to-head diagram and say which is the one that's giving us the best efficacy. But at the same time, we need to look at numbers needed to harm as well.
Yeah, thank you so much, Dr. Kunti. That was a very eloquent lecture.
We
should discuss at the next session. We move on to the next session or the next lecture by Dr. Sanjay Agarwal. Dr. Sanjay Agarwal is the Honorary Secretary, National RSSDI. He's the organizing chairman, IDEC. He's a very busy clinician and is director of the AGEL Clinic in Diabetes Care in Pune. He's also the head of Department of Medicine and Ruby Hall Clinic. He is well known